My name is Navdeep Kumar. I'm a consultant in Special Care Dentistry based at University College London Hospital. And I'm just going to provide you with an overview of the oral and dental implications for those people who have sickle cell anemia. And there's three main objectives for this discussion today. One is just to understand what happens in the mouth and to the teeth in individuals who have sickle cell anemia, and just how you look inside the mouth and what to look out for, and then what to do about it if you do see something that looks a bit different. A common question is, once you do find something that you think you might need some specialist dental help for, who do you send that patient to and how? So why this is important, because you're not dentists as an audience, well, because we know that the population of patients is increasing with sickle cell disease and mirroring that increase. So people with complex medical issues, comorbidities, we are seeing that they need to access specialist care, be it dental or medical. But unfortunately, if you just step back a bit, you can see that 50% of the UK population do not access a dentist regularly. So some of the patients you will come across, if you tell them to go and see a dentist, they won't have one. So therefore, you have an important role as a non-dentist in trying to identify what's happening in the mouth and preventing indeed any problems, any infections which may compromise their sickle cell disease, and knowing what the emergency management is and onward referral. Thinking about the mouth we use to speak, talk, swallow, communicate, for social interaction. So unsurprisingly, there's a really strong link with quality of life. And if you think about infection risks from the teeth, the mouth, the soft tissues around the head and neck, it is associated with hospital admissions and morbidity. What about the oral manifestations of sickle cell disease? There isn't a strong evidence base in the literature regarding the incidence of these, or indeed the nature of them. So most of it is descriptive from the studies that are available. The implication of this is that a dentist on the high street may not be fully aware of the orofacial manifestations of sickle cell disease, and perhaps those living in London with a much more diverse population may come across it a bit more often, but those in other geographies around the UK will have potentially very little understanding of what to do with a patient with sickle cell disease. But sickle cell disease and the mouth are interrelated, because if we can try and do some really effective prevention, we can prevent the infections that could trigger a sickle cell crisis, and we can improve their quality of life and minimize oral disease and discomfort. So what we really need to try and do together is do some effective screening, signposting, and just do some earlier detection and management rather than dealing with the acute emergencies. So we're going to do this together. We have done a Mentimeter exercise when this lecture was given as a live event, but some of the details I'm now going to discuss with you. So the orofacial features of sickle cell disease, as I mentioned, evidence is relatively poor, but I have collated into three areas: what happens to the bone around the head and neck area, the teeth, and the mucosa. And just stepping back a bit, why is it so important? Because actually pain around the orofacial region can potentially be due to numerous causes. We think about the teeth and decaying teeth, but you could get problems with the jawbone, either avascular necrosis or infection within that causing osteomyelitis. And with chronic anemia, you can get changes around the orofacial tissues, either ulcers or burning mouth. Gum infections have been described in this population. And sometimes when you get pulpal necrosis, you can have a tooth that's painful with no apparent decay in it. So we have to think quite hard when a patient reports pain in the mouth or the facial region. So the first area where I've put some of the findings that have emerged from the literature is the jawbones, facial and jawbones. And we know that there are changes in the skull because of bone marrow expansion, and you get this hair on end appearance. But it's also been described that the upper jaw, the maxilla, can appear protruded, and that's because the bone marrow space within the maxilla expands, and that's variable. So it's not predictable in all patients, but it's something that is more commonly described than some of the other features. Depression of the nasal bridge has been described too, and that can potentially have some ramifications for the ear, nose, and throat team. And the condyle, which is essentially how you open and close your lower jaw at the jaw joint, avascular necrosis of that jaw joint has been described, leading to difficulty in opening the mouth. Osteomyelitis, because of hypoxia, particularly occurs in the mandible, which is less vascular, the lower jaw, than the upper jaw. And something that I have seen on a number of occasions is neuralgic pain, numb chin syndrome, because you get vaso-occlusive change around the area. And when you do the cranial nerve examination, you can see really oddly, with no apparent pathology, either clinically or radiographically, a change in the feedback that you get from a particular area where neuropathic change has occurred. But if you ever look at radiographs of the jawbone, either a skull radiograph, because it's unusual for you to request more specific scans of the jaw, you may see areas of radiopacities due to previous infarcts as well. For those of you who may be able to access imaging of the teeth, either because they're on the system from another colleague, maxillofacial or dental colleague, the teeth may look a bit different as well. And that's because there might be a thickening or white line around the teeth, and that is called hypercementosis. Essentially, the teeth are superglued into the jawbone, and that can lead to difficult extractions. So here you can see how the jawbone looks a bit different. This is a dental panoramic tomograph, a low-dose scan of the jaw, and the two sides of the jaw look very different here. And on the other side, you can see here osteomyelitic change and breakdown of the jawbone. That's the mandible looking down on it, and as you can see, there's breaks within it. The jawbone can look very irregular in 3D scanning imaging. This is sort of, I appreciate you won't see radiographs of teeth very often, but there's a sort of fuzzy outline around the root where it sits in the bone, and it should be much cleaner and sharper than that, and that's hypercementosis. So the second area where one can get change is in the teeth, and the teeth in relation to how they come together or bite, the occlusion. So malocclusion is more commonly described in patients with sickle cell disease. It can either be that the upper jaw protrudes over the lower jaw, overjet as we call it, or open bite where the teeth don't meet at the front. And that, again, connecting back to what we know happens in the jawbone, is related to the fact that the maxilla, the upper jaw, can expand. The teeth may come through at funny times, often delayed, and that can be due to growth delay observed in patients with sickle cell disease. Now, the issue of dental decay is an interesting one because patients often come in saying, my teeth have decayed because of my sickle cell disease. But really, this is a multifactorial reason for the dental decay. The studies have demonstrated that actually the dental decay is not directly related to sickle cell disease. There is no change in the integrity of the tooth, the thickness of the enamel, or the quality of the enamel around a tooth. And it's more likely that the increased rates of dental decay in this population are because of lack of regular dental care, occasionally dry mouth. Patients can be tired, poorly motivated because of their systemic disease, and they may not have access to a dentist. The teeth, as I mentioned, the enamel being under-mineralized is an inconsistent finding and not evidence-based. I mentioned a bit earlier that you can get pulpal pain because of necrosis inside the pulp of a tooth, and that's due to bone infarction. And that's a really odd one because you might have the patient going to see the dentist with pain in a tooth, and the dentist saying, well, it looks perfectly okay in the mouth and on the radiograph, so it's fine. But they may not be aware that this feature can occur. So just some x-rays, some images to demonstrate what we've been talking about. On the side on my left, you can see the teeth and the gums, and they look a little bit yellowish. They look a bit spaced. There are some missing teeth in here with some gaps. On the right side, you can see really advanced dental decay, and there is plaque sitting around the necks of the teeth and very swollen gums. So the third area, so we've done bone and teeth. The third area is soft tissues. Unsurprisingly, you can get changes in the appearance of the soft tissues because of anemia. They may appear pale. Hyperbilirubinemia has been shown to cause a yellowish tinge of the gums as well. And we saw that a little on the previous slide. And anemia is associated with the tongue feeling atrophic or thinner and uncomfortable and painful as a result. Again, with gum disease, patients do come in saying my teeth are loose because of my sickle cell disease, but actually it's because of oral hygiene not being optimal, and that results in infection around the gum, causing the bone around the teeth to shrink back and mobility of the teeth. How about Candida? Well, that is more commonly described in this population and is thought to be related to anemia and potentially long-term antibiotic use. Folate deficiency has been described fairly consistently of causing burning tongue and burning mouth, where the tongue may actually appear on examination clinically normal, but there is a deep burning sensation that the patients describe. So when we look at this is just to orientate yourself, the back of the mouth with the upper jaw there and the throat, the soft palate. And this curd-like appearance is very typical of pseudomembranous candidosis, although it can present in different ways. A little bit of a close-up of it. And here you can see hepatic infections, deep seated ulcers, which look really different from something that we call aphthous ulceration, which is not as deeply seated. Antivirals typically given to resolve this, but it can be difficult to manage in the shorter term and extremely painful. Hepatic infections, of course, can occur extraorally, and this is division 2 of the trigeminal nerve, where this gentleman has these deep-seated painful ulcerations. So how about dental management? There is some reference material in the standards for clinical care of adults with sickle cell disease in the UK, and that is a good resource if you wish to go back and review some of the information that we've discussed. The standards really focus on not dealing with the emergency acute care, but really trying to prevent oral infections. Because absolutely, when they've got an infection, it's a bit late. They've got some significant disease, and high-dose antibiotics need to be prescribed early and at the right dose to prevent a sickle cell crisis. Practically then, patients need regular care, preventative care as well, and they need to be seeing the dentist, particularly for a comprehensive assessment about the age of 12 to 13 when the adult teeth are emerging, particularly because we've mentioned that malocclusion is more common. So these things need to be picked up early and a plan put in place. And the same thing accounts for any changes in the jaw, the teeth, and the soft tissues. If these are picked up earlier, they're much more easily managed. And at all times, if something is detected, then talking to the haematology team early for dentists is essential. So they shouldn't be working in isolation of you. So this is tartar or calculus, a bit like the inside of a kettle, that hard coating, but this is full of bacteria and it's glued onto the surfaces of the teeth. All is not lost though, because if this is removed, you can have on occasion quite healthy teeth underneath, but that calculus could cause gum disease if it's left untreated. So having understood the importance of oral care in this cohort, the fact that most people won't have dentists, what do you do when patients come to you? You may pick something up and yet they don't know where to go and how to get help. Essentially, dentistry is a shared care model. Of course, there are urgent care accessible hubs, emergency dental hubs, still accessible through NHS 111, and patients can go to accident emergency with acute infections, particularly when there is facial swelling, when there is an increase in temperature, when there are other systemic signs and symptoms. Those patients should seek help immediately. But generally, ongoing support for a patient is in the primary care dental services, of which there are actually two types of dentists: the general dentist, the generalist who sees all patients, and a community dentist. Now, the community dental service is where you get specialists who are more experienced in treating patients who have additional needs. And this includes medical needs or medical support. If your patient is below the age of 16, they would access the pediatric dental services. And if they're 16 above, the special care adult services. This is similar to secondary care. So why would patients go to secondary care or hospital settings such as where I work? And that's not for continuing care, but it's for specific items of treatment that need specialist input, either because of the complexity of the dentistry or because they need supportive adjuncts, perioperative nasal oxygen, if they have secondary effects of their sickle cell disease, which require additional support, for example. But just to be really clear, the secondary care dental services are not commissioned to provide continuing care. So the general advice is that it's got to be coordinated, the care, whether it's primary or secondary, we're in it together. The dental and the haematology team are linked. We need to consider the timing, and we may shorten visits. That might be some advice you give to a dentist if the patient has a poor tolerance and is tired quickly, and additional risks associated with sickle cell disease and its ramifications should be highlighted to the dentist so that they can make appropriate adjustments. Transfusion is not often required, but if there is some surgery, for example, with the maxillofacial or surgical teams, special care dental teams undergoing quite invasive surgical procedures, then that is a consideration that can be discussed. And of course, infections must be treated aggressively to avoid crises. So invasive surgical procedures, post-operative antibiotics need to be discussed. And if somebody is missing a spleen because of autosplenectomy or spleen removal, prophylactic antibiotics, depending on the invasiveness, particularly of a surgical procedure, are often discussed as well. So we try and avoid general anaesthetic and sedation if at all possible, of course, because of the anemia. We try and avoid drugs which may cause hemolysis and worsen the risks when treating the patients, such as KEFs, cephalosporins. And of course, we avoid aspirin. Prilocaine is a dental local anaesthetic which causes methemoglobinemia, but it's rarely used. And there is some evidence, however, that it is best avoided in this group. So practically, we worry about this, don't we? If we haven't had a patient accessing preventative care, a broken tooth with a gum boil on the side, that's a dental abscess draining through the jawbone and causing a bubble of infection, which if that bursts causes pus to leak inside the mouth and a sinus. So the guidelines regarding antibiotic prophylaxis do vary from country to country. In the UK, there are Royal College guidelines produced by the Faculty of General Dental Practitioners, which dentists follow, but they will ask for your advice regarding it. Now, increasingly, patients ask about dental implants. This is really visible in the media. They want a nice smile, and they often come and ask for these. It's really important to be aware that they're not routinely funded on the NHS. So sending somebody to a dental hospital for dental implants is not, if they don't meet the criteria, is not likely to result in funding. There are only 3 groups, which are people born with missing teeth, for example, those with cancer, and those who have complex reconstruction requirements. So the key thing is to be viable, and if you take all other factors away, the patient must have really optimal oral hygiene, because poor oral hygiene results in implant failure. And smoking and bruxism or tooth grinding are risk factors, again, for failure of dental implants. So if you were considering sending somebody for dental implant assessment or having a discussion with the patient about them, and you're aware that those risk factors are there, it's important that you can have that discussion that dental implants aren't for everyone. And they have to be able to tolerate the surgery. So if they're systemically compromised, they can't tolerate longer appointments, and they may not be suitable for surgery. Really, although there are no medical conditions that absolutely contraindicate dental implants, the key is that they have to be well controlled, mouth has to be clean, and it's good to avoid other risk factors such as smoking or tooth grinding. Example of what a dental implant looks like. This is one that I popped in with. It doesn't actually take too long. It's all the planning that is really important, but you have to raise a gum flap up in most techniques. Some are now mini implants put through without a flap being raised. But just an idea, when somebody is talking about dental implants, you do need to be aware of the invasiveness of what they're suggesting. So if a dentist is not involved in the patient's care plan, it is important to have that discussion. Say regular oral care is important every 3 to 6 months. Now you know that that could be with a general dentist or with a community dentist. If your patient with sickle cell disease is more complex, you can make that referral, the GP can make that referral, so it doesn't need to come from another dentist to the community dental service. Fluoride toothpaste and mouthwash are really good to prevent dental decay. Chlorhexidine mouthwash is good for gum disease, not used long term because it can cause a bit of staining on the teeth, which can be polished off, but nevertheless, it's not something that we recommend long term. And brushing twice a day as a minimum, morning and evening, not eating after you brush your teeth at night, because that will mean that you've got lots of substrate for bacteria to grow overnight when the saliva is produced at a lower rate. A small pea-sized amount of toothpaste, and really not to eat or drink generally 30 minutes after brushing. Most important rule is spit, don't rinse, because if you rinse all the fluoride out after toothbrushing, you've lost all of its potential positive effect. Toothbrushes, well, as a minimum every 3 months, or sooner should the bristles get frayed, should these be replaced, and much smaller than most patients normally purchase, because they've got to get small enough to brush on the outside of the teeth, on the inside of the teeth, and on the biting surfaces, and in between any gaps. If the mouth's too sore, there are other things that can be considered, but generally we would recommend a normal toothbrush, not a soft one, as we sometimes recommend in those with bleeding tendencies, because it won't remove the plaque as effectively. Fluoride toothpaste can also be prescribed in addition to that which is purchased, and supercharged fluoride toothpaste can be prescribed by the dentist and the GP. So there are two different strengths there. So we do need to then just pause and reflect. What we've learned so far is that the bone, the teeth, the mouth can be affected. It's really, really important to focus on picking things up early. But then the dilemma is that most people don't have a dentist. So there is advice produced by Health Education England for those professionals who are not dentists to see how they can look inside the mouth. And the tools really are here, which you've got a small-headed toothbrush, gel, non-foaming toothpaste if you can't see what's going on in the mouth, and the denture pot. And you just basically go through lips, tongue, teeth, cheek, dentures. And here you can see a healthy mouth, a not so healthy mouth, which is cracked, and a swollen mouth with lips. And this is available on the Health Education England website. So let's have a look at this close-up of the upper lip, and that's a cold sore, which is just sitting on the top of the vermilion border. And you can see it's much more significant here in somebody who is medically compromised. You can get herpes labialis much more extensively and much more frequently. In the corner of the mouth, this is where saliva pools, and it might be mist under facial hair. You can get a break in the corner of the mouth, known as angular chylitis, with a mixed population of bacteria in it. And this is commonly seen in slightly older patients where the skin fold becomes more pronounced, and it can be extremely uncomfortable if left untreated. This is oral ulceration within the mouth. So again, herpetic infection with serosanguinous crusting around the lips, and the lips are painful and sore. So the next thing is the tongue, a healthy tongue to not so healthy tongue. The one on the right is a huge carcinoma growing on the side of the tongue. And here you can see Candida does not have to be white and curd-like. It can be an appearance which looks rather red and glassy and shiny on the surface of the tongue. And here you can see a tongue that is fissured. Perhaps you can see on the right side a little map-like area, white lacy surround. That's actually called geographic tongue or erythema migrans. And that's a variation of normal. But what can make the tongue really sore, particularly if you've got underlying anemia, is acidic food like tomatoes, for example. Things to avoid if you've got a fissured tongue and you've got underlying anemia. This is carcinoma, a deep-seated indurated ulcer on the border of the tongue. The next thing to look at is teeth and gums. You can see from clean teeth to really broken down, decayed teeth on the right. And really, when we look at teeth, just as a reminder, you may have come across that we have 8 teeth potentially in each corner of the mouth, a total of 32 in adults. And if the teeth are lost, then you've got problems with eating, obviously how you might feel about yourself, how you interact socially. And teeth, when they get to this stage with large amounts of deposits, lots of repairs, those fillings that you can see that have got a bit discolored at the top, staining from smoking around them, this is going to be a challenge to sort out. Here, you may be able to see that there's a really broken down tooth with an overlying abscess on it. And that, again, will be difficult to manage if prevention is not effective and a tooth gets to this stage. Very commonly in young adults, you get this. This is a swollen gum flap or operculum overlying an erupting wisdom tooth. And then you get jaw pain, which goes right up to the ear and the jaw joint. This is called pericoronitis. And in a young adult where these teeth are emerging through, it's often a cause for a referral, and you'll see it in your patients with sickle cell disease. And you can see a tooth just emerging at the back there in a slightly older patient. So just to remind you, wisdom teeth can be problematic a bit later in life as well. This is bleeding gums, which is causing some serosanguinous exudate to stain the necks of the teeth. So how about the cheeks, palate, and under the tongue? Here we go again from a healthy tongue on the left to tongue on the right, which is very dry and painful with ulceration. And here's a cheek where you can see Candida. So just to remind you that you can get candidal infections on the cheeks, not just the tongue, or indeed the palate, which you can see here. What's unusual about this is it's got a really sharp outline, and that corresponds to the denture. So this is somebody who doesn't take the denture out at night, and the denture is a perfect reservoir for Candida. And infection sitting inside the denture can cause this really atrophic red appearance. And this is a much more advanced case of acute pseudomembranous Candida, which potentially is extending down. And if that is, this is what we can see in the mouth, but what's hidden further down is going to be a cause of concern. This is ulceration in the corner of the mouth. This is actually herpetic ulceration, just to remind you that ulcers can occur in the roof of the mouth as well. And finally, dentures. If a patient has a denture, it's the key thing that happens, particularly if your patient is admitted, is it's lost. And it's really frustrating, isn't it, when a patient loses their dentures. You may phone a dentist, there might be one linked to a hospital where you work, but you will be told that a denture takes, on average, 5 visits, 2 weeks apart. And the practicalities of making it on the ward are such that patients, if the denture is lost when they're admitted, they will not be leaving with a replacement. So it's even more important just to look at it. When the denture comes out, if it looks like the picture in the middle, then that's really bad news for the mouth, and it should be cleaned in the same way that teeth are. And we can see, what about cleaning then? So this is advice about cleaning dentures. Never over a sink without water in, because the most common thing that happens is that it slips out of someone's hand and cracks in two. And again, thinking how difficult it can be to replace, that then is going to pose a problem. So the patient should leave a denture out at night. It should be labelled and brushed and cleaned. Sometimes if there's candida in the mouth that you've seen, chlorhexidine is quite useful just to brush it and clean it. So what's the take-home message from all of this? So sickle cell disease can give rise to a wide range of oral manifestations. And of course, if you've got poor oral health, be it in the bones, the teeth, the soft tissues, you can get significant morbidity. And the dichotomy here is that 50% of your patients will not have a dentist. So you can try and signpost patients for oral care. And now hopefully you have an enhanced understanding of who does what within the dental field. But essentially all healthcare professionals should have some understanding of what to look out for in the mouth, what that might mean for the patient, and what early interventions could be put in place. So those were our learning outcomes. Hopefully we've all got a better idea of what can happen in the mouth, what to look out for, and how to look at the mouth, of course, what looks normal, what doesn't, and just understanding that once we've picked up something that's happening around the head, neck, and the mouth, the teeth area, that there are different people in the dental field that provide different types of care for the patient cohort. Thank you.